Okay.
Awesome. Well, yeah, thank you guys for coming out and showing some support. Most of you guys know me, but I'll kind of go through a bit of an introduction for myself and my background for those who will be watching this recording. So yeah, my name's Madison Hickey, and I'm just going to switch slides. Let me know if this switches okay. Does it switch?
Yep, that switched.
Great. A bit about my professional background. So I graduated from St. FX in 2018. So I've been practicing as a registered nurse now for the last 6 years. I kind of started more so in the cardiac surgery department of the Halifax Infirmary. Working there for a few years, I continued to get educated in more acute care settings and ended up working in CVICU, which is the intensive care department of that surgical department. So the patients will come out from the OR and we'll admit them directly here. And you can kind of see a few of us there in the photo on the unit where we practice. And yeah, since I started there in 2019, so it was very interesting timing. The pandemic hit really shortly after that, and I remember the first day they took masks out to the nursing station, and we were all a bit confused by it, and that's been here to stay in Nova Scotia at least. So I continued practicing there for about 2 years, and then I left to start travel nursing in 2021. And I went out west, and during that time, I kind of noticed in each work environment I was in, there was a lot of nurses who were struggling with burnout. And we saw that a lot throughout the pandemic with short staffing and increased job demands and people who were kind of struggling to adapt and to all of the changes with COVID. Um, so I kind of got interested in this work just through my professional experience, and I ended up connecting with Dr. Janet Curran and Dr. Christine Cassidy, who's here today, and they kind of encouraged me to enter the program at Dalhousie, and I started to investigate this more from like a research perspective versus more of my personal experiences. So in doing that, I was able to find that this is really been a big issue in the nursing profession in the last since COVID, but even before then, there's kind of been historical trends that have led to a reduction in the supply of nurses for clinical practice. So the World Health Organization predicts that there will be a shortage of 5.7 million registered nurses by 2030. And in Canada specifically, there's over 100,000 nurses that will have a deficiency in by 2030. And these statistics were before the pandemic. I've done this presentation before, and people have asked if there's updated stats, but I haven't been able to find any. So if anybody knows of any, please feel free to share. But the projections haven't really been redone in the last few years. So on top of that statistic, there's also 42% of nurses who are planning to leave nursing altogether in the next 5 years. And nurses under 30 kind of represent the greater intention to leave than other age categories. And in the work that I've been doing, I'm noticing that there is a higher percentage of nurses who are kind of in that between 40 and 50 age bracket. So with such a reduction and so many people who are leaving, there is quite an issue. And a big reason for this issue is this concept of nursing burnout. So what is burnout? So burnout's kind of a triad of these three concepts. The first one being depersonalization. So more so meaning that you can't connect with yourself or the people around you, and you're kind of just, going through the motions in your day. You don't feel overly connected. The second being emotional exhaustion. And again, this is kind of to describe burnout broadly, but you can probably see in terms of like what nursing care requires, why emotional exhaustion would be a big factor. And it's more so having to care for people and the public and seeing people who are really struggling. You end up as a nurse, being there with them and absorbing a lot of that emotion. So the second being emotional exhaustion, and the third is a reduced sense of personal accomplishment. So specific to nursing, you can kind of see this when there's a number of tasks that you have to do in the run of a day, but your workload might be such that you're not really able to, from like just simple facts, you can't accomplish all that you need to get done in the run of the day. So you leave your shift or your day feeling like you're not really able to be productive. So my scoping review is going to focus more so on critical care nurses. They're at an increased risk for experiencing burnout, as they're more emotionally influenced from responsibilities of caring for patients who are experiencing distress, suffering. They're witnessing medical futility in care, meaning having a lot of medical devices on board, and engaging in those ethical decision-making skills around end of life and communicating with patients and families up until sometimes their death. So that's kind of one of the many reasons why critical care nurses are at that risk for experiencing burnout. So the consequences are really far-reaching and complex. And what I've been finding in the literature is that a lot of these interventions are targeting the individual. So some of the ways that they do that are through mindfulness-based programs, or through resiliency programs, or team building. But really, there's more of a deficiency in knowing between the organizational and systematic layers what interventions can we use. And that's really where it matters to kind of stick in healthcare. So in the individual, consequences of burnout are mental and physical health diagnoses. More so the mental diagnoses are more well documented. The physical health diagnoses are kind of more in tandem with shift work and the effects of that on a person's physical health and circadian rhythm. But this includes anxiety, depression, post-traumatic stress disorder, sleep disorder, and substance use disorder in nurses. Organizationally, this has been an issue as there's increases in job demands and workload, as I had just mentioned. Rationalizing of nursing care, meaning where you're not able to physically perform everything that you need to do, there are certain things that you end up skipping out on, and ultimately that affects the patient and compromised quality of care. We've also been seeing increased organizational costs and commitment as there's been higher turnover levels in nurses. And then systematically, all of this manifests into a reduction in the collective public health. There are more poor patient outcomes and patient safety risks as nurses aren't really able to do their jobs as a result of this, emotional exhaustion and experience of burnout. And there's been higher turnover rates and nursing shortages in the healthcare industry. So what's the gap leading to this research? As I've said, there is a lot of literature on the concept of burnout in nursing. It's been very well documented. However, it's a problem that hasn't been fixed. We're still seeing that in clinical practice now. And there aren't any reviews that are using a knowledge translation approach or implementation science approach to understanding the multi-contextual levels of the hospital environment that's responsible in influencing critical care burnout. Like I said, a lot of this just is related to the person and individual interventions. So efforts are needed to address this gap and come up with innovative solutions to create positive, lasting, and meaningful change to better the state of healthcare and improve the health of our providers and patients alike. Because when there's a healthier provider, they're able to kind of give themselves to work in a way to support patient health, and they're more in touch with themselves, which allows them to be more connected with the people around them. So the research question that's guiding the scoping review is what interventions have been used to address burnout in critical care nurses throughout and after the COVID-19 pandemic. Like I said, this is kind of going to be plotted in a micro level, meso level, and macro level factors for nurses in acute care settings. There's a few sub questions that I'm curious in answering as well. The first one is, what scales are used to report on rates of nursing burnout, moral distress, stress of conscious, well-being, PTSD, depression, anxiety, and or secondary trauma, which are all names of psychological effects of nursing burnout and working in acute care. Second, I'm interested in knowing what theories have been used to inform nursing burnout research. And finally, what knowledge translation strategies have been used to implement interventions. So to do this, it's going to be plotted on this framework, which is the ICON framework. It's been developed to kind of acknowledge and address the context in nursing. It's been proven that to create lasting positive change, interventions should target all of these levels to have the best chance of uptake. And using this framework, these factors will be organized and will inform the implementation of this work. So here we have the micro level, which includes the actors or the participants, and in this case, that would be critical care nurses. The second layer looks at the meso level, so organizational factors, and they're kind of listed here: the processes, responsiveness to change, social behavior, and structures. And then the macro level looks at external influences such as policies or politics and community beliefs around nursing burnout. So to complete this research project, as I've mentioned a few times throughout, I'm going to be using or doing a scoping review, and that will be in accordance with the JBI methodology for scoping reviews. And then I'm also really interested in using a knowledge translation approach to this work that engages leaders and critical care nurses to help increase the uptake and get their opinions on, you know, if what we're finding in the literature is really speaking to their own experiences. So to do that, there is an active framework, which I'll be following. It kind of provides 12 stages in which these leaders and knowledge users are able to be engaged, so they can be more involved in the research process. So thankfully, Leah, who's on this call, is going to help me with this more so tomorrow. I'm really in the early stages of this work, but just developing a search strategy. I'm considering, in accordance with JBI, the population concept and context. So I'm really interested in registered nurses' experiences, as they're typically the nurses who are responsible for caring and managing care for the patients in acute care. And that will be in a critical care setting and with critical care nurses. The concept, which I've explained a few times, is burnout, as well as kind of these mental health effects of burnout as well. And then the context is inpatient hospital setting, in acute care, critical care, and or intensive care. So the inclusion criteria for this scoping review will include any study design reporting on an intervention for nursing burnout. As I'm looking more so into the effects of COVID and how that has shifted the landscape in nursing, hoping to get articles that are published between 2020 to present day. Really focusing on including studies that have published on knowledge translation frameworks or strategies. And the setting would be inpatient hospital wards, critical care departments, or acute care departments. And this kind of something that I've been going back and forth with, because the experience in intensive care would be a bit different than in the emergency department, but there are times when a lot of these experiences are similar, and maybe you don't have time to transition a patient from the emerge into a ward or into the ICU. So in that case, you're really dealing with that critical moment and experience of what the patient's going through. If they were just in a car crash, let's say, or they come in with sepsis and they start crashing. It with patient flow, it depends a lot on the bed situation. So I've kind of been toying with the idea back and forth if emergency departments would be included in this. I'm happy to hear your guys' input as well. And again, it would kind of be reporting more so on registered nurses' experience. And in terms of exclusion, I would exclude any literature that is based on conference abstracts or commentaries, study protocols, non-studies, or simulation studies. I just don't believe that that would be an accurate representation of what's happening in the clinical context, and that's really what I'm curious at getting at. And unfortunately, I do speak French at times, but I'm definitely not affluent in commenting on literature that's in another language. So for that barrier and reason, we're only including English language studies. So non-English language will be excluded. And I'll also be excluding articles that are written on other hospital wards that are not in a critical care or acute care. And there has been, in my preliminary search, there's a lot of literature on physician burnout, but I'm really trying to just get at registered nurses to try to keep it really contained and feasible. So although I think it's really interesting in how burnout might differ depending on the care provider, in the context of this work, I'm just going to be looking at nursing. And then to analyze this data, the data is going to be, so thankfully, through Dr. Janet Curran and Dr. Christine Cassidy, I've been affiliated with their research team. And there's been a few people who have agreed to help me throughout this process of, and the JBI scoping review process, you do some title and abstract screening, full text screening, and then you kind of move into the data analysis piece. But it's a lot of work to do alone. So through that connection, I'm able to kind of craft a team helping me with this project. And the title abstract screening process and full text process will go through 2 independent screeners who are looking at the inclusion and exclusion criteria and determining whether or not that article should be included in this review. And then when we move on to data analysis, I'll be crafting a data extraction tool depending on the initial research question and sub-research questions, and going through more of an iterative process in refining the data extraction tool with the use of the team. And yeah, it's good for consistency and validity and reliability too, just to have a few people who are able to give opinions on that. And once that form has been decided on with the team, we'll kind of go through and pull out the data and extract what we're looking for, and hopefully come up with a toolkit at the end of this project to give as a resource for critical care nurses and organizations on how they could implement some interventions to mitigate nursing burnout. So that's all I've got. I'm really happy to have a discussion about this work, or any people who have suggestions for how I could kind of shift things. I'm very much in the early stages of doing this, so it's a really great time to get people's opinions and comments on either their own clinical experience or from a methodology perspective, if there's anything that I could tweak there. So yeah, I'll kind of open that up. Thank you guys for listening.
Thank you so much. Yes, open to questions, comments, suggestions.
Oh, Christine, I see you have your hand up.
Can you hear me okay?
Yeah.
Yes.
Okay, great. Great presentation, Madison. You did a really nice job describing a complex phenomenon and how you're going to study it. I'm curious, just based on your own experience, I know you've done lots of reading so far, where do you think most of the interventions that you will find will fall when you think about kind of that individual level, team level, organizational system? Where do you think most of them are going to fall? And in follow up to that, are you anticipating a gap in where they should be, what level they should be addressing? Yeah, I'm just interested in hearing your thoughts on that.
Yeah, that's a great question. So a lot of the preliminary work has really focused on the individual, and it kind of places the responsibility on the individual nurse to, outside of working hours, to do, mindfulness programs, or they speak to having one kind of workshop training session and then noticing like a 90% decrease in nursing burnout. And I do find that hard to believe. Again, and there's been kind of resiliency training that's worked within the team to do the similar things. And it has proven to be effective, which I'm sure it is, if that is something that has a lot of consistency and uptake. Organizationally, what I've seen more so is different leadership styles and how that can either like contribute or mitigate nursing burnout. Some of them that have been effective have been leading authentically, or this concept of authentic leadership. And then there's also been this, I can't remember the name. It's like trans something leadership, but it essentially means just like really being encouraging and motivating staff, and to kind of produce a shared goal. But I found there's definitely a gap, mostly in the system, the systems level layer of like how nurses or mitigating burnout could kind of be impacted by, how we deliver care as a healthcare system. And then apart from the leadership qualities organizationally, I haven't seen many tactics that have worked. The work that's most closely followed, I think, a really rigorous process of trying to make some changes. Sunnybrook in Ontario, they actually had a study where they went through the K2A approach, which is a knowledge translation methodology to help nurses who are struggling with burnout throughout the pandemic. And they have had like some coaching sessions and really commented not only on like what the coaching sessions look like, but also like the environment that they did the sessions in, having access to internet and Zoom, and really commented on some of those contextual layers. So I think that will be a great study to kind of pull from for this work. But yeah, I would say the organizational and system level are definitely lacking.
That's really interesting. And I think teasing apart those components of the interventions when you do extract them will be really helpful. So awesome. Thanks.
Yeah. Awesome. Massey, what do you have?
Hi, Maddie. It was really great presentation. I really enjoyed. One thing came to my mind. I'm talking about like my experience and my point of view. I think if you consider emergency units as acute care, it makes sense to me, because I consider emergency units even sometimes more intensive than ICUs, because there's more turnover and probably there are more conflict and challenges there. So I thought you're like a bit too minded about this. From my point of view, yeah, if you consider emergency as acute unit as well, that would make sense to me.
Yeah, no, that's really helpful because it has been something I've been trying to understand. I don't want to make it too broad, but I also think that there would be a lot of value add for including that department. So yeah, thanks for your suggestion. That's great. Thanks, Massey.
No problem. Thank you.
Does anybody else have any questions, comments? I see one in the chat. There's a comment from Erin in the chat. Great presentation. Love to see how your proposed thesis has grown over the last 18 months or so.
Yeah, thank you guys all for coming. It means a lot to have your support, so I appreciate it. And yeah, really great conversation too. So thank you.
Thank you so much to everyone for coming, and thank you, Madison, for presenting. And thank you.
All right, thanks, Julie, for hosting this. And hopefully I look forward to coming to more of these and seeing more of the research going on at the school. So I appreciate you guys giving this platform for us to come and share our research too.
And thank you. And if you know anybody who wants to present, just email me and we can set up a time and a date that suits. So yes, spread the word. We're always looking for people.
Sounds good.
Thank you.